So good afternoon, and I would not take time. So let's start with the case. This is a 17-year-old who has come with complaints of diplopia and esotropia since 6 months. Old photographs show orthophoria, wearing glasses for several years, screen time 6 to 8 hours, best corrected visual acuity 6.6, ocular motility full, fundus examination normal. This is his cycloplegic refraction, and because he had acquired esotropia, MRI was done, which was normal. And this is him looking at, as you can see here, right esotropia, and right eye has more myopic. If you remember, ocular motility is full. So this is how a typical anterior acute comitant esotropias, acute acquired comitant esotropias present. Of course, this patient received injection Botox in the right eye, and this is him 6 months later after the injection with esotropia gone, and this story ended happily. So acute comitant esotropias are rare, 0.3% of childhood strabismus. Acute onset esotropia with comitant deviation, basically ocular motility is full. They do present with diplopia. Younger children may not have diplopia, and most people who are affected are either older children or adults. These are the postulated etiological mechanisms, and which are very a large group which is unclear etiology, and a large group which has probably excessive smartphone use. This Korean article has very specifically said a smart use phone of more than 4 hours is very much a risk factor. And of course, a big risk factor here of myopia also. So classically, they have been classified in these groups, but there is now a little bit addition of a type 4, which is a refractive accommodative esotropia, which can come as acute, and a type 5, which is associated with intracranial lesions. So what causes the esotropia? Basically uncorrected myopia, because Bielkowski's type is the most common, and uncorrected esotropia coupled with excessive near work leads to an imbalance between the converging and diverging forces, leading to the increased tonus of medial rectus and esotropia. Again, AAC associated with excessive smartphone use probably has the same mechanism like Bielkowski's type. And as I mentioned earlier, others which are like AAC associated with intracranial disease or accommodative AACs have a different mechanism for having acquired esotropia. So there is another rare type of esotropia which is secondary to accommodative spasm, which is a slightly different etiology. Again, it's rare and due to excessive stimulation of accommodation, and it may present with blurring, intermittent diplopia, and fluctuating refraction, and esotropia and diplopia occasionally. Responds well to cycloplegics. For some time they may be required for a very long time, and orthoptic exercises. Recurrences, again, please remember, are common, and cycloplegics may have to be applied for a much longer duration. So again, this is a case where there is a 28-year-old with these clinical features. He has come with a refraction of -4 in one eye and -4.5 in the other. Right esotropia, visual acuity poor, and we put him for atropine refraction, and on day 4, when we saw him again, his visual acuity unaided was 20/20 and refraction was +0.5, and he was surely a case of an accommodative spasm. He was prescribed homatropine, which did not work. Review after till still had ESO and myopic refraction, so he was shifted on atropine drops. He had to be on atropine for almost a year before we could stabilize him with 20/20 visual acuity without atropine and orthophoria. So this is him when he get presented, and you can see a small right esotropia, but very poor vision, and I don't have his post treatment pictures, but he was orthophoric, no diplopia free, and 6.6 unaided. Role of neuroimaging in these cases, should it be done in every patient? Controversial, because gain of neuroimaging is very low, but comitancy does not necessarily rule out any intracranial cause. So it may be the first and the only sign of an underlying serious neurological cause. The list is which mentioned here, and it should be probably carried out in all patients who are presenting with some kind of neurological symptoms like ataxia or blurry disc margins and things like that. So in addition to the rest of the workup, you should definitely ask for neurological signs. Some of them are not volunteered, but if you ask the history, they may be, you may see them. So how do we approach? So these are the history which you need to take: any history of occlusion, previous strabismus surgery, monocular vision loss, myopia. Look for neurological signs, and if they are present, do order a neuroimaging. orthoptic evaluation for the objective measure of accommodation, rule out accommodative spasm, Vergen's abnormalities, and routine squint evaluation and cycloplegic refraction. Management, observation in certain cases if it is acquired and patient is not too symptomatic. Restriction on near work or smartphone or gadget use has probably improved the comitant esotropia in 1/3 of patients, but remaining 2/3 patient, it really is not effective, and the evidence on this is a little divided. Prisms can help for symptomatic alleviation of the diplopia. Botulinum toxin injections have worked very well, and all of us have seen an uptick in these cases in the last couple of years, and there is enough and more evidence available, including at least 2 Indian studies which have reported good results. One was from our group and one was from Arvind Eye Hospital, where they have 60 cases, and our series had 23 cases, which had all shown around 50 to 60% improvement in patients with botulinum toxin. And of course, there is a remaining group where you probably may have to think about surgery. So in case of negative neuroimaging, and if you are waiting for establishing the stability of angles before planning surgery, observation is a good rule. You can ask for smartphone restriction during 1 month when you are waiting. Again, botulinum toxin, as I said earlier, comparable results. Exact mechanism is not known, but probably it induces a microscopic anatomic changes at neuromuscular junction, and it should be promptly administered after diagnosis. Sometimes both my study and Dr. Sandra Ganesh's studies feel that improvement with botulinum toxin is much better and much if you have given it early in the course of disease, and if the angles are mild to moderate and not really those who come back with 60 and 45 and 60 prisms. So advantages of botulinum toxin: shorter GA, cost effective and minimal disruption of extraocular movements. Downside, transientosis and sometimes large angle exotropia in few patients. So this is the evidence, as I mentioned earlier. So this is a successful case following botulinum toxin. We gave you can see left esotropia, and this is her after 3 months after surgery, and as you can see, she is maintaining orthotropia with good alignment. Surgical management, again, biomedial recession is the surgical procedure of choice. You may need to modify surgical dose because in these cases of acute acquired esotropia, the effect of surgery on medial rectus is slightly lower than what our normal tables suggest, and probably you have to slightly modify the surgical dose. Results are good, and restoration of binocular function and resolution of diplopia occurs in most of the patients. Recurrence rate is low, but longer from. So this is one patient who developed acute acquired esotropia. She was my patient before developing esotropia, and she suddenly came with this full ocular motility, and this is she after surgery, several years after surgery. This is not at the time of surgery. So you can see with glasses she is maintaining good alignment and good motility. So future ahead, we need comparative studies between the users of between excessive gadget usage with and without AAC. We need long-term follow-up on surgical outcomes of BMR, and we need to establish the mechanism of AAC in myopes and low hyperopes who do not have excessive near work and psychological stress. So these are the take-home messages. Thank you for your attention.
Thank you, Dr. Sumita, for a very nice talk. We are short of time. One thing I wanted to say that some of these cases with neurological disease, they may present as an isolated way, and that may be the presenting sign.
Yes.
So there may be nothing which could be sort of supporting. So those cases need to be seen more carefully.
Yeah, we have had, I think, 60 cases in the past 5 years, which was very high number for this. And we found tumors in 2. So yield is low, but I think it is the best use of 8,000 rupees where the patient can afford.
And if the ESO is more for distance, it is more, that's could be one indicator. If there's any nystagmus, all those things have to be seen together. And fundus also, you have to see the disc and rule out papilledema. You should not overlook that.
I think now we already crossed the time. Now, as president of this society, I thank you all very much, all the delegates and all the speakers here. And we'll see you again in our midterm conference in Cochin.